Good morning. First, I'd like to thank SAGES and our moderators for the opportunity to present our work today. And we're going to present on an algorithm for the approach of gastroesophageal reflux disease after sleeve gastrectomy. These are my disclosures. After the study period of this talk, we actually have engaged in a study with Torax looking at the effect of links on reflux after sleeve or magnetic sphincter augmentation, and I will be discussing some off-label use. So sleeve gastrectomy is obviously the most commonly performed weight loss procedure in the world, and we know that reflux after sleeve has been recognized as a vexing problem, hence the prior two talks that we had here this morning and this whole session. And really many mechanisms for reflux after the sleeve have been proposed over the last several years. And many of these reasons center around the morphology of the sleeve itself. And so many mechanisms have been proposed as to the reasons why patients develop reflux after a sleeve. Also, many mechanisms have been proposed as to how to prevent reflux after the sleeve. And the prior speaker really presented a nice algorithm. And in response to these problems, the primary solution that's been offered to patients is that if you develop reflux after a sleeve, that you should be converted to a gastric bypass procedure. There are other solutions that have been discussed in the literature, but mostly a case series discussing magnetic sphincter augmentation, radiofrequency ablation, and hiatal hernia repairs in these patients. So our hypothesis was that really the mechanisms not only surround the sleeve itself and its morphology, but that we should look at our principles of esophageal physiology and the anatomic contributors to reflux disease and the anatomy at the GE junction. And whether the patient has a hypotensive LES, the presence of a hiatal hernia, do they have transient LES relaxations, are any of these contributing to the reflux that the patient has developed after a sleeve? And so we aim to answer two questions. First, do all patients who present with reflux after their sleeve have to be converted to a gastric bypass? And can an evaluation for reflux using the objective studies facilitate an algorithm for other ways to manage reflux after a sleeve? So we began managing our patients with this scheme in January of 2012. And our inclusion criteria for patients were any patients who presented with persistent symptoms of reflux after a sleeve gastrectomy. Primary symptoms patients complained of were heartburn and regurgitation. Obviously, they had to be after a sleeve and their symptoms were not controlled, or they could not stop their proton pump inhibitors after their procedure. All of these patients underwent an extensive workup with endoscopy, esophagram, high-resolution manometry, and either a 24-hour pH impedance study, or if they weren't able to stop their medications because their symptoms were so severe, or a Bravo study, and then they underwent symptom questionnaires. The interventions that were offered to the patients were conversion to a bypass. They were offered hiatal hernia repair. They were offered an LES augmentation. They were offered possible radiofrequency energy delivery. And at the time, after the thorough workup was completed, we went through all the testing and had an extensive discussion discussing all of these different options, as really in the literature, there's no predetermined best way to manage these patients. And then we would make a mutual decision as to how to proceed. And so this study reflects the retrospective review of how this approach fared for our patients. We identified 53 of these patients between January of 2012 and December of 2017, and at least the patients had to have at least 6 months of follow-up and be 6 months post their sleeve. And all patients underwent a modified GERD quality of life, as this also included the questions on regurgitation, which was a very common symptom in many of our patients after their sleeves. And these are their demographics. In general, our patients were middle-aged, primarily female and primarily white. Their BMI, mean BMI was 36. All of these patients were post-sleeve, and many patients were no longer obese at the time of presentation. The GERD HRQL scores preoperatively were high. Demeester scores were also high in our patients. And the mean LES pressure was normal, was 20 millimeters of mercury. Many of these patients' comorbidities had resolved at the time of their conversion, but there still was a smattering of diabetes, hypertension, sleep apnea, depression, osteoarthritis, and hyperlipidemia. So let me walk you through how our patients fared as we went through, put together this algorithm. So 31 of our patients actually did get converted to the bypass. And the reasons that we used to convert them to a bypass is if their BMI remained over 35, or if those patients were identified to have abnormal sleeve morphology. 13 patients underwent magnetic sleeve augmentation. 7 patients had a hiatal hernia repair only, and 2 patients underwent radiofrequency energy delivery. And LES pressures were lowest in the magnetic sphincter augmentation group, as that was one of the inclusion criteria to choose this option for management of their reflux. And there was a significant improvement in GERD-related quality of life in these patients in all groups. So this is kind of how the algorithm breaks out. If a patient has a BMI over 35, they have abnormal sleeve morphology, or the manometry shows high pressure within the sleeve, as shown in the first talk earlier today, then those patients were converted to a bypass. However, if none of those features were present, then this allowed us to offer patients other treatment strategies. So almost a third of the patients could undergo something that was not a conversion to a bypass, and really based on the principles of LES function. We would assess their manometric findings. They all had to have pathologic reflux based upon their pH studies. And if their LES pressure was less than or equal to 18 millimeters of mercury, then we looked at magnetic sphincter augmentation. And if the LES pressure was greater than 18, then we offered them radiofrequency ablation. And this was really the smallest group of patients. Only 2 patients underwent that. And then any patient who had a hiatal hernia underwent a hiatal hernia repair in combination with any of these interventions, as that's an important component and contributor to the incidence of reflux disease and the pathophysiology of reflux. If we look at the GERD HRQL scores, this is kind of a busy slide, but I want to bring your attention to a couple of the questions. The patients with 5 being the highest, their heartburn significantly improved from pre-op to post-op. And also the regurgitation significantly improved from pre-op to post-op. I think one of the things that's really notable in these patients is the diet, right? We talk so much after bariatric surgery about diet, and many of these patients could not eat the way that they were supposed to eat after their bariatric surgery due to their symptoms. And so they attributed their symptoms to really contributing to their ability to follow a proper bariatric diet, and this significantly improved after the procedures were performed. It is well known that there are several studies out there that sleeves worsens reflux. Of course, there are a lot of studies that also show that patients improve their reflux, and that's the basis of this whole session here today. We ourselves have presented data at this meeting talking about the impact of the sleeve morphology on reflux disease, and that proper morphology can decrease reflux in our patients. There are traditional interventional approaches to reflux, including LES augmentation with fundoplication, which is no longer an option for these patients as the fundus has been removed, or magnetic sphincter augmentation. And then we do have a tool to address transient LES relaxations. And then these patients, of course, can undergo hiatal hernia repair. And after significant weight loss, hiatal hernias that may not have been significant can become a lot more significant. So this is the first objective algorithm defining parameters for choosing the management of reflux after sleeve gastrectomy. If we look back to the aims of this study, do all patients have to be converted to a gastric bypass? And the answer is no, they do not. Can we objectively determine other solutions? And the answer is yes. So GERD after a sleeve gastrectomy is unique. If the patient does remain obese or has sleeve abnormalities in their morphology, then consideration for revision and conversion to a gastric bypass is warranted. However, if those parameters are not present, then we really should work up the mechanisms of their reflux. We should always address the hiatal hernia. Hiatal hernia is an important contributor to reflux disease. Have a toolbox that you can offer the patient to address the abnormalities of the reflux in today's day and age, and consider conversions, of course, for the anatomic and obesity issues. And finally, prevention may be a part of the cure. We still don't have a standard way the sleeve is performed, and there's more and more data coming out that these technical points change the reflux after the procedure. And then perhaps, similar to the talk we just heard, further workup for GERD in patients with preoperative symptoms may be warranted to prevent this problem postoperatively. Thank you very much.